Thank you everyone for joining us today. As you see, we today are getting to learn more about HIV treatment. And I want to talk a little bit about the Addis Clinic for those that are new to us or for those that have not yet reached out to us. My name is Anthony Kimathi. I'm the country director for the Addis Clinic. With me in the panel here is Dalal Kob Najia, our executive director, and our able, our always around Dr. Paul Hart, that is always there to take care of us, has always been there for the Addis Clinic. All gratitude. I know this team knows that there is nothing that Dr. Paul doesn't want to make sure that we get to learn from the cases, from the webinars, from everything. Anytime that you reach Dr. Paul, he is always around and willing to help. Thank you so much, Dr. Paul. He is a face that most of you are familiar with, and most of the webinars that we have managed to conduct, he has always been part of the webinars, whether on the side or as there was one of the panels. So with the Addis Clinic, as you all know, we offer telemedicine services to every part of the country and outside the country. For everyone that is here, if you have not yet registered with us, let me just share my number, 0712 559 438. My email is Anthony, Antony, at addisclinic.org. I will type everything in the chat box. So everyone that is here, please, if you don't have an account with us, if you don't know how our platform works, if you don't know anything about the Addis Clinic and you wish to get an understanding of how the Addis Clinic works, please reach out to me. I'm always available and always willing to help out. Dalal too, our executive director, is always available and willing to help. And everyone that works with the Addis Clinic, when you go to our website, that is www.addisclinic.org, please, you can go and check out all our programs, everything that we do. You can find anything, any questions that you may need to ask, you can leave them on the website, or you can directly send them to us. For the ones that would love to get the recording of this webinar, you can reach out to me too, and I will try my best, because I will get the list of the participants and send it out. We have more than 1,000 clinicians on our platform that are regular users. I would love to just say, anybody that has an account before or has an account, has had an account with us, but most probably forgot their password, you can still reach out to me too. We do these monthly webinars with you, and we're in the process of accreditation to make sure that you get CPD points for the same. Thank you, everyone. I will hand over the mantle to Dr. Paul to start on the new updates and new diagnostic treatments and comorbidities associated with HIV. Thank you so much. Dr. Paul, well, the floor is yours.
Thank you so much, Anthony. Many years ago, I'm Canadian trained, but I moved to the United States to practice. And many years ago, I went to a conference. And at this conference, the CDC, who is the American body that talks about, that helps with medications and helping physicians and the country with their medical problems, presented at this conference, which was a general medical conference, about a new illness that they had started to recognize. They didn't have a name for it, but it was unusual and different from what they were seeing. That was the first indications of HIV, way back when. So since that time, and we're talking 20 years, give or take, now, of course, this is a major worldwide illness, but we have had major advances. And I'm going to start by just sort of going a little bit over HIV, what's happening with it, how it influences other illnesses. Um, One of the comment I want to make is thank you everybody from the Addis Clinic, people who are coming. You folks do an amazing job with extraordinarily complex problems. Okay, next slide, please. Okay, there is a global HIV epidemic. 37.7 million people worldwide have HIV, 1.5 million new infections yearly, 690,000 deaths per year. And not everybody, unfortunately, knows that they're HIV positive, only 84% of people. So this is a major challenge worldwide, not only in Kenya, but around the world. And what we're looking at is that there's been major progress in treatments, but also given that information, HIV deaths are still a major problem in all countries, but especially countries that do not have significant medical resources, what we call the low and middle income regions, where it's difficult to get testing and care and also the new therapies. And that will come up as we go along. Next slide, please. Okay, so how does HIV, what happens? The virus enters our cells at the top of the pyramid. It binds to and enters the CD4 plus and the T cells at its target. The virus then starts replicating itself in the body. It then, as you move down to level 3, it starts effectively destroying the immunity of the person who's been infected. So our normal response to another infection or a problem is reduced. And finally, when as the virus is taking over, you have a weakened immune system, and the patient is susceptible to multiple problems. So this is what is happening from the time we have viral entry until the patient now is susceptible to all types of infections and problems. It doesn't happen right away. It happens over time. I had a patient years ago who became infected. We don't know when, but over a number of years, he slowly started having problems after problems. And eventually, this was before the medications that we now have came out, he passed away. The death rate has gone down tremendously since the medications have come out. It's not zero yet. Keep going next, please. Okay, so what is new in HIV? There are newer ways of diagnosing it. So now, and I don't know, unfortunately, and this is my problem, how many of what I'm talking about or how much of what I'm talking about is available in Kenya, because we have now rapid tests where when a patient comes into a provider's office or to a screening clinic, you can get a diagnosis in 15 minutes. You don't have to send the test away and wait. You can actually now have self-testing kits at home for people because people, at least patients in the United States, and I'm sure Kenya is no different or other countries, are embarrassed or don't want to come into a clinic and say, I may have been exposed to HIV. But if you have a test kit at home, you can check. And the actual diagnosis has improved. So we can get earlier diagnoses rather. And what's very important for HIV to see what the viral load is, how much virus that patient, that individual is carrying around, because it gives us a help and aid in treating the patient, as you know. Next, please. So what we call point of testing, the rapid testing, 15, 20 minutes, which means the patient can be tested right away. And once the patient is tested, we can now start right away counseling the patient. Now, before you test a patient, you always talk about the test and about the illness. And then once you get the result, if a patient is negative, that shouldn't end it because we're still obliged to talk to the patient of what they can do in the future to ensure that they do not become infected, safe sexual practices. But if they are positive, what that means, what the next steps are. And then, of course, as we said before, the self-testing, where these patients can then come in, if it's positive, hopefully, and start on their treatment. So the point of care testing is part of the advancement, and the rapidity of testing is part of our advancements in HIV. And again, I don't know how fast you get a test in some of the clinics where you are. Hopefully it's quick and will be improved as these tests become more available and more reasonably priced. Next. Now, home-based testing, again, these tests are easy, they're confidential, you don't have to go to a clinic, you can get earlier diagnoses, and then hopefully the patient will come in to see you earlier. Again, I'm not sure how, and maybe Anthony can answer. Anthony, do you have home-based testings now in Kenya?
Yes, yes, Dr. Paul, we have them.
Oh, beautiful. So so that's something providers should encourage patients who may be at risk to say, if you don't want to come here for a test, you can get your home-based test. And that, because it's important of discussing sexual activity with our patients. I started in the United States with patients age 13 and up because I had a young lady who was 13 come in pregnant. So I don't judge anybody, and I talk to every patient about it. It's something I think that is important when we work with our patients. This is not only about HIV in general. Let's move on, please. Okay. It's very important that we monitor the viral load because it tells us how effective our treatment is. And you can see that we're being either helping or do we have drug resistance or a treatment failure. And the best way of knowing is to do a viral load. And I'm sure you folks are doing that. It monitors the level of the HIV RNA in the blood. Suggested for stable patients every 3 to 6 months on treatment. So even if somebody's doing well, we call our patient back in, we do the test, and we're able to tell the patient, sure, stay on what you're doing, or if the viral load is going up, we have to change or modify our treatment. And if you have less than 50 copies per mil, you know that we've been effective and reducing our risk of transmission. And just introduce something here that's new, and I'll talk again at the end. The New England Journal of Medicine is one of the major worldwide medical journals. And yesterday, the January 2nd, 2025 article, they had a review article on long-acting HIV medications. And they reference a study that was done in Africa, plus some other countries, with an injectable medication given to women who are at risk of developing HIV. It was, in the first study, 100% effective, and the second study, 96% effective. And this was an injection that was given, it was called the PURPOSE study. It was done in South Africa, Brazil, Mexico, Peru, Thailand, and the US. And it gave 96 or 100% protection, and it was by injection. So it wasn't a pill the patient took every time. So there are some really major advances that are coming that are going to be able to prevent HIV. Next, please. Okay, an update. There are new drug classes that are coming out all the time. And they're listed here. Oh, and by the way, all our slides are available to you. I believe Anthony has sent an email out, or Will, you can reach Anthony and he will send you this entire slide pack. So there's no need to take notes, of course, unless you want to. But there's new drug classes, and the long-acting injectables are mentioned here. And the advantage to that, of course, is you don't have to take a pill once or a number of times a day. Some of the injectables are every 4 months. So it really starts expanding our options. The drugs are more tolerable than they used to be. When they first came out, there are a lot of side effects. They're much better now. And also now we're able to tailor or monitor or adjust the therapy based on a drug resistant profile. If your viral load is going up and you're resistant, we can change it and we can minimize complications. And you know, I'm only a family doctor, and in the US, if I identified a patient, I would send them on to an HIV clinic where they are doing that. I don't know, again, in Kenya, how many of the HIV clinics you have, and I would imagine in some of the more remote areas that the primary care doctors are providing this type of service. Next, please. Okay, these are the new drug classes. The attachment inhibitors, and they block an interaction between the virus and the CD4 receptor cells, so the virus can't get into the cell. And then the what they call the maturation inhibitors, and these disrupt the final stages of the viral particle assembly. Again, it prevents the release of the virus. And then they can neutralize antibodies, and they neutralize a number of HIV strains. And finally, on a new technology, gene editing therapies. So you can see these are all new classes of drugs, and over time we'll be seeing new members. Unfortunately, and I don't know about the situation other than the US, some of these medicines are very expensive and are not easily available when they first come out. And indeed, I mentioned about the long-acting drugs, and in the same article that I referenced before, they said that the drug company can make for 40 US dollars, I don't know what that is in Kenyan funds, but it's not a lot of money per year, enough medicine for a patient. The cost to the patient in the US right now is between $25,000 to $45,000 per year. So the drug company is making it for $40 or $50 a year, and look what they're selling it for. So now this is obviously going to change, but it really eliminates the use of these medicines in a lot of places, because that is a horrendously expensive treatment. Even though it's life-saving, it's prohibitive for most folks. Next, please. Okay. Now, other new parts of the antiviral, they're changing the dosage frequency. Now, instead of many times a day, once a day, and in some of the injectables, up to every 3 or 4 months, one injection. And it also, because people with HIV can suffer, this I dropped down to number 3, I'm sorry, instead of going to 2, because people can suffer from TB, malaria, other chronic diseases, they're modifying the drugs. So when a patient has another disease, it's safer to combine this with the medicines that they're taking. The safety profile has been improved, because before, liver toxicity affects our bones. It can have neurological complications. As the drugs are being worked upon, these complications are improving. And obviously, what you folks are doing, monitoring and managing it, is becoming easier as these other improvements occur. Next slide, please. Okay, so what do you do now when you have a patient who's HIV positive, and they have other conditions. They're diabetic, they're hypertensive, they have a mental health issue. How there's new information how you coordinate the treatment so it addresses not only the HIV, but the other conditions that the patient has. We have to look for, and this is something we've been doing already, this is not new, we have to look for drug-drug interactions and adjust our dosages to minimize the side effects. And sometimes, and it's on both sides of the equation, how we dose the HIV drugs and how we dose the medicines for the other condition, the diabetes, the hypertension, or whatever the problem is. And often in the US, and I'm sure it's in Kenya, we need a number of specialists. The primary care doc, who should be the person who's in sort of the captain of the team, and then your chronic disease experts who give their separate advice and expertise. And I don't know how often in Kenya people run drug interaction checks, but when you get a patient, as you know, who is on multiple medications, the risk of drug interactions starts increasing. And so what I like to do, and I don't know if that's something that you have easily available, is a drug interaction checker where you can put in all the medicine and they'll say this medication could interact with that. Now, maybe you will take that risk because they're both critical medicines, but at least you're aware of it and could look out for possible problems. But that's something that'd be worthwhile if you don't have, for us to work on from our end to make sure we can provide that to everybody. So that's just one extra suggestion. And then, so we've got to coordinate interaction and the disciplinary approach. Next slide, please. Okay, what happens if a patient has HIV and TB? Very common, unfortunately. Because of you have HIV, you're at higher risk of developing TB. Your immune system is compromised. You're exposed to TB, and in certain parts of the world, and you folks are in one of them, TB is a common infection. Actually, in the United States, there is more knowledge being given or sent to providers to say, don't forget TB. It's not an illness that has gone away. And with international travel, a patient can leave India in the morning and be in the United States in the afternoon, bringing drug-resistant TB with them into the US. So it's a problem now which is worldwide, and if being in an area where it's endemic, it's even more important. And it's really important that we screen, and now we're going not into new stuff about HIV, but we screen our patients who have IV to make sure that they don't have TB as well. And you don't just do it once, because so until you've got that viral load down to it's really, not detectable, they're still at risk. And then you have to manage the two together to give the treatment for the HIV and the TB. Next slide, please. Okay, so you you have to look at it's all this is you integrate HIV and TB treatment. You manage your drug interactions. You try and minimize by what you suggest. And what you want to do is you develop the you initiate your HIV TB co-infected patients to manage the immune reconstitution inflammatory syndrome, the IRIS, using steroids, which can delay ART, which can delay this syndrome. Next. Okay, malaria, another major illness in your part of the world. Again, people are more susceptible when they have HIV to getting malaria. So there are interactions between the drugs for malaria and for HIV. co-infection can lead to more severe malaria, but you can also have anemia in more frequent problems, and mortality is increased higher than if you had just one infection. You know, there's a risk of dying from HIV, there's a risk of dying from malaria. You combine the two, you're at greater risk. So you have to do as best you can preventing the patient getting malaria, infected treated bed nets, indoor spraying, and of course, treating HIV. So these are all strategies which all providers who are seeing HIV or patients with malaria should be aware of. Next. Okay. I'm sorry that didn't come, but high blood pressure can happen when you use the HIV medications for patients as a side effects. We've got to be really careful that we monitor the blood pressure, the cardiovascular status. Also, you can get diabetes problems. We get insulin resistance and altered glucose metabolism. So again, our diabetic patients who have HIV have to be monitored more closely. And as you know, many patients with diabetes also have hypertension. So it's not just looking at one, it's looking at both of these illnesses in addition to treating the HIV. And so again, it's a multidisciplinary approach between your primary care, your specialist, and any other doctors who may be involved with the case. And one problem that we have often in the United States is one doctor treating a patient being aware of what another doctor who's treating the same patient is doing. So communication between doctors is critical and one of my roles as the sort of the gatekeeper, the primary care, is to make sure that I communicate with the specialists and the number of specialists, so one specialist doesn't provide a treatment which could interfere with what another specialist is doing for that patient. So that is, really important and difficult to do. It's time consuming, but it's critical for our patients. Next, please. Okay, integrated care is, where we now are making physicians aware of managing the diabetes, hypertension, mental health problems with HIV. I don't know what community-based programs you have in Kenya, but if we get community health workers out to the population of the patients who have HIV to make them aware of resources, to make sure that they go to appointments and follow out. And then telehealth. And this is something that, of course, the Addis Clinic can help you with, that if you have a problem or a question about managing a patient who has HIV with any of the conditions we've mentioned or anything else, you can reach out, and we do have experts. I'm only a family doc, but we do have infectious disease experts who can help you guide and treat that patient. If you don't have a local expert who can see the patient, we can be there for you to try and help the best that we can. Next, please. So what are the barriers? Why do people have problems? Well, there's this stigma of having HIV. Most of us, if we have a cold, if we had pneumonia, we don't mind telling a friend, oh, I've just had a bad cold, I had pneumonia, I fell and I broke my wrist. Very few people say, I'm going out for my HIV testing, or I just tested positive for HIV or negative. It really is difficult for patients, often even to come into providers, feeling that we as a provider will look down upon them or will judge them. And we have to be very careful as providers not to judge our patients. There are barriers which occur not only in Kenya to get HIV services, but in the US, where in smaller communities where they only have a local primary care provider who's not an expert in HIV or in cardiovascular medicine, or people who have HIV with other diseases, for these people to get access to treatment. As I mentioned before, when I talked about that very high cost from one of the new injectables, financial restraints. And I don't know how much the government in Kenya provides um, for HIV testing, medications. I know that the United States does provide or did provide HIV medications to a number of countries, but still um, there are financial barriers, and that becomes a real major problem. And then also, our healthcare system is being overwhelmed as people come with more and more severe problems. We have a shortage of well-trained healthcare workers. We have problems with weak supply chains. In other words, getting information out, getting medication out to the providers and to the patients who need them. Again, this is one of the roles that hopefully the Addis Clinic can help people with, where we can provide education um, and access for providers to help with their patients. The others are difficult bearers, and that's something that's being worked upon literally worldwide. Next, please. So, how do we improve on what we're doing? Community engagement. If you have a community where you have services, make sure that they're reaching out to patients with HIV, potential with HIV, educating, going into schools as possible. Every place you can do education is critical. In the US, and I don't know about Kenya, we have mobile testing units. Before I came on today, I was doing telehealth in the US, and there's in Tennessee, which is one of the states which has more rural population, and this organization has a van which goes out to these small communities with an exam bed and a nurse, and the patient can come in and be evaluated and tested. Using digital technology. Again, I don't know, this is not available uniformly in the US, and I'm sure Kenya is no different. And then, of course, using our local resources to help patients get transportation to where they can get their treatment, help them get the child care if they have to leave for getting testing or treatment for a period of time. So these are all things that we can try and get done in our communities. You can do in your communities. I don't know how easy it is. I don't know what resources, but the worst that can happen is we reach out to a group and they say they can't do it. And if they can do it, our patients benefit. Next, I think we're almost there. Okay, we have to address the stigma and the discrimination. Education. Empowering people who live with HIV to let the community know that you can live now virtually a normal life with HIV. Yes, you have to take medicine. Yes, you have to be careful, but you can live a life. You can be productive. You can, have a normal job. And also the rules and regulations in the country. So we don't have discrimination, something that, if you've been listening to the national news, present in the United States and unfortunately worldwide. And the more we can do by trying to strengthen and promote anti-discrimination is so important. And now I'm talking not only about HIV, but any other illnesses. Next. Okay, so new HIV prevention. There are new gels and rings that are being developed, and it can spare or can help women where their partner won't use a condom. The long-acting injectables, which you mentioned earlier, where you can get once a month or every few months an injection. Much easier for a patient to come in or self-inject. I know there are many medicines in the U.S. That patients now self-inject, the biologics that they can do it. And if a patient who's not able to do that for some reason or has a fear, can go to a provider's office. this antibody-mediated prevention. So you can get an infusion, an IV of HIV neutralizing antibiotics, and this is the way to get immediate protection against infection if you have a high-risk population. And we're getting to the point where we're going to get effective vaccines for HIV. So we're in the article in the New England Journal, which I referenced earlier, they looked at the stages of HIV. And the first stage is when we found out about it. The second stage they talked about when we first started getting drugs. And now they feel we're entering the third and hopefully final stage where we're going to get to effective treatment and prevention. And just like we can prevent measles and other illnesses by an injection, hopefully HIV will be in that category so we can eliminate this illness or control it like we do other diseases, which will be a major and worldwide advance. Next. Okay, now this is just something about community organizations. If you can reach out to the organizations in your community using asking them to try and help talk about all the issues that we have talked about before, using what we call grassroots organizations that are there to help people who have HIV to live a normal life, to get the rights of access, to tailor their services to get, they're not stigmatized against, to build trust with the communities, and to be innovative in the way we treat HIV and the communities that regard and help people with HIV. Next, please. And okay, what's in the future? The new therapy, we are getting to a point where we're going to cure it. Personalized medicine is coming on all fronts, where we don't just say you have HIV and you're on a standard therapy. We do some studies about the patient, and based on your genetics and your biochemistry, we give you a treatment which is designated as being effective for you as a patient, rather than you as just you as an individual, not you as an individual who has HIV and I treat you the same as every other patient. And that's where we can tailor therapy. And that's going to come to other illnesses too. And then using digital health to improve the testing and our monitoring. So this, but it's going to be many faceted, a lot of folks involved, and it's still in the future, but it's coming closer than it was 20 years ago and 10 years ago. Next. And that's it. Thank you very much. I will try and answer any questions. If I'm not able to answer a question, I will send Anthony the list of I'll look up the answers, send it to Anthony, and he will send it to you. But if you think of a question after we're finished, please reach out to Anthony. His contact, he said, is in the chat, and send him a question. He'll forward it to me and I'll get it back to you. And we'll share everybody's questions with everybody else, because I think we all learn best in learning and supporting each other. Thank you, Anthony.
Thank you, Dr. Paul. I think we have around 10 minutes, but we have around 7 questions here. If you are still in the meeting or in the webinar and you have a question, please type it in the Q&A section. If Dr. Paul doesn't respond to it now, I will get back to you. He usually responds to the questions later within 24 to 48 hours. So please, you can get the responses through the email that I sent it in the chat, or the phone number that I included in the chat. So the first question that Dr. Paul, we have in the chat, or we have in the Q&A, is how accurate is the oral HIV test?
I believe, okay, I'm going to research that. I believe they're extremely accurate, but I'll get you a exact number, and depending on the type of test, because that's an excellent question. and I don't know the percentages, but I will. Can I ask a question? Is it feasible for your providers to do drug interaction screening?
No, for the settings that they are in, it is hard to get a drug interaction screening at DIS.
So if I could find an app that does drug interaction screening, could it be sent to everybody to use?
I will make sure that everyone gets it. If
Okay,
they
let
can
me
have
find out
an
what's
app,
available,
yeah,
because that would be really valuable, because as you know, as I don't care what medicines we're on, there's always the potential for interaction. And the more medications a patient's on with, the more problems, diabetes, hypertension, arthritis, HIV, and now they come in with a pneumonia. On top of that, we're talking a fair number of medicines and a fair number of possibilities of interaction. If you can get a guide to say, yes, this antibiotic is safe and it won't interact versus another, it's going to be helpful for your patient and for you. And they are available. I'll find out. We'll get one to you to send out to everybody who is on our list, because I think that would be really a helpful benefit for everybody.
thank you so much. I will do that. I will
Okay.
make sure that everyone that is in the
Okay,
list
we'll
of
get
the
it.
Addis
It'll be
clinic will
done.
get it.
Okay, next. I'm sorry.
Okay, the second question is how does HIV get contracted from the mother to the child?
Okay, mother to child, it can go, it can cross in utero.
And
But the
with,
exact about the exact mechanism,
yeah,
I'll find out. So and I'll find out at what stage, how HIV
and
crosses.
and in breast milk,
Okay, and breast milk, yes, I'll find out. I don't know the answers because, as I say, I have not treated a lot of HIV patients. I have to research this. I will get the answers for that for sure.
thank you so much. There is a question by Jeremiah. Do you see development of a technique in future where HIV markers can be detected in exposed person who did not develop HIV disease as a result of interventions, such as in PEP?
So are there going to be markers to see whether I've been exposed and I do not develop HIV?
Yes.
I'll find out. It's a good question. I do not know. Okay, markers. In other words, markers for exposure in non-infected people.
Yeah. And please, when Dr. Paul says that he will respond to these questions, he sends out a detailed explanation. So please, if you want responses to these questions, I will send them out, but sometimes I don't get the emails that I've subscribed to the webinar. So the phone number that I gave out, my phone number, please send me a text. Just send me and ask me, did you get the responses to the questions? And I will forward them through your email.
And I will have the responses to Anthony by tomorrow at the latest.
Yeah, thank you.
So you'll get your responses by Monday, for sure.
So everyone that is asking questions, because I see questions are still streaming in, please reach out to me 0712 559 438 or my email anthony@addisclinic.org, and I will send everyone a list of the responses from Dr. Hart. So the next question is, how effective is pre-exposure prophylaxis and post-exposure prophylaxis for clients who are sex workers?
Okay. Oh, good. Yeah, pre-exposure and post-exposure. From the study, this one study, and I'll get more information, but for this one study where they talked about pre-exposure in women in these countries that I mentioned, it was between 96 and 100%. There were two separate studies. So it was very effective. Now, I don't know about sex workers, because with sex workers, you're talking about maybe multiple exposures rather than, having one or fewer, one or maybe two partners. So that's an excellent question. I'll find out. Pre and post exposure with sex workers. Okay, we'll find. I don't, and some of these questions, I'll look in the literature. I don't know whether we'll be able to answer them. They may or may not have been studied. They're excellent questions, but we've got to find some researcher who's gone out there and looked up the information. So I'll do the best I can.
Thank you so much. And
Yeah.
something that I want to point out to everyone that is in the team or in the webinar, one of the injectables that is getting studied in South Africa is known as lepanavir, and it is getting studied by, actually it has a 100% efficacy if used after every 6 months. And it's actually getting studied by one of our biggest funders for the HIV program, Gilead Sciences. And they have seen a lot of results in it. And I just wanted to give a shout out to Gilead Sciences. They are one of our grantors for the HIV program that we have in Western Nyanza, Kenya.
Oh, yeah. And it's very interesting because they have had other innovative therapies and made a major difference worldwide with once they have an effective therapy. If we can get a really effective pre-exposure treatment, that's going to be a major, major worldwide breakthrough.
Thank you, Dr. Hart.
Yeah.
Dr. Paul, what is the correlation between HIV and hepatitis?
It's okay. I'll find out more. But the people who it's partly, I think, the drug interactions for the treatment. But I'll find out, how HIV, how it affects hypertension. So HIV and how it affects
hepatitis.
Okay, so if high blood pressure, hypertension, hepatitis, yeah, well I'll find out more information, but it's immunosuppressant. HIV suppresses our immune system. So therefore, any other infection is going to be potentially more serious. And that talks your hepatitis, that's your malaria, that's your TB, because now you're immunosuppressed. So if you're more susceptible to the infection, and it can be advance faster in our system if we don't have our own immune system at peak performance, so to speak. But I'll get you more specifics as to what the mechanism it is, for sure. For cardiovascular, or for hypertension, hepatitis, any other illnesses we should add on that? Malaria?
Yeah, and malaria.
Yeah. And TB, of course.
Yeah, TB is the common one.
Yes. I've told, I talked to, this is an aside, but I've talked to doctors here, and when I describe patients who present to your wonderful providers who have HIV, but also have TB, and now they're getting another illness, malaria, they can't imagine seeing one after the other such complex patients. And because if that patient presented in the United States, yes, they would be treated, but then at that hospital, they would be presented at a round because it would be so unusual.
Yeah, and actually something else that you might forget, diabetes.
Yes, thank you. And diabetes. Okay. Will do. Next, you're going to have a little bit of reading to do. Next.
Yeah. So I think for everyone that is asking the question again and again, I will send before the webinar ends. Please send me even an hello. I was in the webinar, and I will get you the answers to these questions so that I don't forget. Please, I request of everyone that is here, if you really need the questions to be answered and you can go through them later, please shoot me a message or an email, and I will attach the responses from Dr. Paul. So I think the next question is directed to me and the Addis Clinic. Does the organization have an health level 7 programs to leverage on data sharing between the organization and other entities, for example, the government? and departments to leverage on service delivery continuous improvement. So this question comes from Jeremiah. Jeremiah is asking whether we have a connection between the government and the organization. This is something that we are working on. We have managed to have interaction or partnerships with around 7 counties in Kenya, and we are growing. We have approached more than 13. The other 6 are in the process of trying to see to gauge how we can work with them. Another direction that we are taking is working directly with the Ministry of Health from the government, from the national government and the county governments, in the sense that they leverage our services, the telemedicine services, but on the HIV services that we have managed to interact with in the 6 counties that we are offering the services are the hardest hit counties in Western and Nyanza, Kenya. And these services are using our HIV messaging and adherence program, where we follow up with patients that are suffering from HIV and follow up and make sure that they adhere to their medications and follow up on their clinics. It's a program that we have said that is getting funded by Gilead Sciences, and but we hope by the start of this year, as we approach Gilead Sciences again, we can get bigger funding to accommodate half of the counties in Kenya. And this can be a plan where now if we continue with that direction, we can cover the whole country by sharing a platform with every county in 47 counties in Kenya on the HIV databases that we have, and adherence and program follow-ups with them. So this is something that is in the works, Jeremiah, and we promise in case it continues to grow, you will be privy to the information. Thank you so much. The next question is, Dr. Paul, a patient once asked me, who is more likely to contract HIV between a man and a woman?
Okay, so so basically, is there a sex difference between in contracting? I don't know. I'll find out. I know, I talk to people, but male or female, both, to be careful for safe sex. But I'll let you know.
Thank you so much. I see Ayo, there's somebody by the name Ayo Surfaced. I see that you had raised your hand. Do you have any question before I continue with the other questions? Ayo, yeah, I can see Ayo Surfaced has raised his hand or her hand. Any question from your side? You can unmute. I think if you have a question, you can unmute. Or if not, please, you can type it in the Q&A and I will read it. I'm getting another question from Charlene Bovi. How do you manage an HIV patient with severe malaria, bearing in mind the drug interactions?
I will write to you about that too.
I know, Charlene, what will happen is that since I even have your number, I will make sure that you will get a response. Dr. Paul will get, when you see Dr. Paul saying, I will get that to you, he wants to give you a detailed answer. He doesn't want to just skim through the answers. He will try and give a detailed, and even sometimes he goes and quotes some journals that you can go and read by yourself.
I'll get you references too.
Yeah, and references. So any question that you see Dr. Paul saying, I will give an answer to that, just know that he doesn't want to skim through the questions or an answer just to answer the question. He wants you to get the full answer to the question. And because of time, it will be so hard for him to go through the answers all at once. I'm getting a question.
So when I give a journal reference, you'll be able to definitely get, if you click on that reference, you should be able to get the summary. Some of them you'll get the whole article, depending on the journal, some of the journals won't give us a full article. They'll only give us the abstract, but at least we'll give you more information.
Thank you so much. I have a question from Illuminata. Welcome, Illuminata. I've not seen you for a while, but welcome again. Hello and thanks for the talk. Kindly expound on the issue of undetectable and untransmissible.
On what, please?
There is a concept of if it's not detectable, it cannot be transmitted.
Oh, okay. So if not
undetectable equals untransmissible.
If not detectable, can it be transmitted? Okay, I'll let you know.
Illuminati, I promise you'll get the response to that too. How effective are the microbicides? Yeah, the microbicides, and are they available here in Kenya? I think this is a question to me, and because I have people, this is a question from Eric Munene. I have a friend. I have Shalin Buvi is a friend of mine, and I think, yeah, he's a pharmacist, and I think familiar with microbicides. And I think they are not that common in Kenya. According to, because I know that if I'm familiar with microbicides, I think Dr. Hart, they are used to prevent, they are applied inside the vagina or the rectum to prevent HIV transmission through sex. And it's mostly a cream or a gel that is applied to avoid, to kill any viruses that they come into contact with. Have you heard of them, Dr. Paul?
No, I mean, I've never, this is new. This was new to me because as I've only been doing a telehealth with folks here in the US. And so I have not been dealing with any HIV patients for years. Yeah, so to Eric Munene, I can tell you frankly that they are not common in Kenya. I know there are some, I've heard of one known as dipivarine or something. It's a gel that is used by ladies to apply. It's a vaginal gel that is applied to reduce the risk of transmission, but since I think it's not common and expensive, it's so hard to come by. And in Kenya, being that in the few instances that I've come across any talk of it, it's not that effective. I think the last time that I checked, the effectiveness is between 80 to 90%. Compared to others that are between 90 to 100. So I don't think it's that common in Kenya. Thank you for amazing presentation. Is injectable drug available for PEP or post-exposure prophylaxis? I think I can answer this to Dr. Paul. Most injectables are pre-exposure prophylaxis. There are some that are post-exposure, but the study currently that is taking place is mostly on pre-exposure, and in patients that rather than being on Hart, they can be on injectable every 4 to 6 months to avoid the pill burden. I think that's the current regimen that is being studied. And the lepanavir that is being studied by Gilead Sciences, if I'm not wrong, it's pre-exposure prophylaxis. But Dr. Paul, the question is on injectable availabilities as post-exposure prophylaxis. So, okay, injectable for, sorry, I don't quite understand.
The question is on the injectables that are currently, because Kenya is not common, the injectables are not common in Kenya. In the countries that injectables are getting used, is it used as a pre-exposure prophylaxis or post-exposure
I
prophylaxis?
will let you know what the role of the injectables is.
Thank you so much.
That's
So
easy.
air surfeit, that one will be responded to in the answers that we get from Dr. Paul.
Good.
Bernard Mutuota is asking, is there a blood group which cannot be infected with HIV?
Not that
Since
I'm
so,
aware of. As far as I know, the answer is no.
yeah,
But
so I think, Bernard, this is a myth. I think this is a myth that has been debunked many times. There are people that say that blood group O is a only carrier, but can't be infected. Bernard, it can be easily infected because it's an mRNA, a type of infection virus. So it doesn't, to my study, to my best of knowledge, I don't think there's any blood group that cannot be infected with HIV. And Dr. Paul, I think something that you will talk about even in your answers is the type of HIV. There's type 1 and type 2, HIV 1 and HIV 2. If you will try and give a brief
okay.
explanation between both.
Okay, type 1 and type, yep, for sure.
I know Dr. Stephen Kigodo. Welcome, Dr. Stephen. He was my classmate. Pleasure interacting with Dr. Paul through telemedicine. As an HIV clinician, all I can say is that we are in line with the international updates. Would you really appreciate an NCD webinar soon? So Dr. Stephen is an HIV clinician. We went to school with him, and I think we were in for our internship together. He's asking whether we can organize non-communicable diseases webinar. This is something that Dalal, Hi, and the clinic team will organize and see how we can include it as one of our webinars for the year. Thank you so much, Dr. Steve.
Would he like to do that with me?
Yeah, so Stephen, I will organize it because I have his number. I will organize.
I'd love to do a joint webinar with one of your providers. That would be really, we can communicate back and forth with information, do a PowerPoint presentation together and present together. That would be wonderful.
That will be great. So Stephen, that's a challenge for you. I will talk to him because I have his number. I will organize with him on how we can create one and then present. You both can present.
Yeah, the two. Oh, that would be a really wonderful presentation.
Thank you so much, Dr. Paul. Illuminata, the question is, does it mean that these people do not need to use protection?
I see your question there because I just pulled it up here. I think that means if you've gotten the shot, okay, do you then just go about what you're going to do without using extra protection? Or should you still use protection? I believe that's the question. I'll get the right answer. I would imagine that, I mean, I guess it depends on how many levels of protection you want to have. Even though you've had the shot, if you want to be really cautious, you can use protection. Don't think that would hurt you. But is it really necessary, I guess is the question.
So the question is mostly on the injectables if an extra protection is needed. And to me, I think as you get answers to that, you can never be sure enough. That's the main thing.
Yes. I mean, that I agree with your feeling 100%. You know, it's just being like extra safe, and which I think is always advisable.
That's actually one of the recommendations because an HIV has been there for the last 30 years, but still getting studied daily. So in that category of protection, I think we are in the realm of saying you can never be so careful. So if possible, advise your patients to to go that extra step.
Yep.
There is a question by Ayo. I read recently that stem cell transplant or bone marrow transplant is curable, can cure HIV. Can you give us more information on this?
You will get it.
Ayo, reach out to me. You will get the answers to these questions. There's a question by Effie. Welcome, Effie. Why are some ARVs or antiretroviral drugs directed to be used only by low economic countries, like in Africa? Are they only effective in these countries?
No. I think why are some, as far as I know, it's cost rather than anything else, but we'll find out. I don't think it's discrimination. I think, just like I mentioned, some of the drugs are so expensive right now. I think it's a matter of what people can afford.
Yeah, so I think Dr. Paul, the HIV treatment and testing in Kenya is free in
Right.
most counties. We have 47 counties in Kenya, and it is managed by USAID. USAID
Right.
is an entity from US where there is government subsidy from the Kenyan government and the US government. Conjoined, they bring drugs and testing to the country, and any change is published or put into effect by this agency, the USAID agency, and mostly it's devolved in every hospitals, level 2 and level 3 and level 4 and level 5 hospitals and mission hospitals in Kenya by the directive of the Minister of Health. So currently the drugs that we get are the ones that can be subsidized. So to the question, to the one who asked this question, Effie, most of the drugs that we get are the ones that can be subsidized from the companies that produce them. So if we have a drug, let's say DTG that is produced by a certain company that USAID has approached to subsidize the medication, and the government of Kenya has approached to subsidize the medication. So jointly, they subsidize the medication for the patients to get them free. And now, if the company agrees to subsidize, that's the medication that we get in Kenya. Not that we get the low quality or the ones, the subsidized ones. We get the ones that the companies that subsidize the drugs for us, or the government of Kenya that is capable to subsidize. The ones that we get are the ones that are subsidized and we get them for free. I think that answers the question, Dr. Paul. So
okay, thank you.
I see a question by Charlene. Does Mbuvi, does the Addis Clinic have courses on clinical HIV management? So, Mbuvi, I will give you an answer to this. What the Addis Clinic does is remote. We work remotely and we offer asynchronous telemedicine services. And the 4 programs that are indicated in our website. So currently we don't offer any courses. The only thing that we offer educational is on the cases that are presented to a platform that able doctors like Dr. Paul can respond to and give you a breakdown of the case or try and help you on diagnosis and treatment of the cases that you send to them. And another thing that happens is the webinars that we get on a monthly basis from different doctors led by Dr. Paul. And these we are working to make sure that they are accredited by the various bodies in Kenya. So besides that, we don't offer any courses. It's something that we can think of later, but currently because of the financial constraint, since we offer everything on a humanitarian basis, we don't charge anything for our services. We are trying to work on a system where we can get more funding for this. But if it so comes, we have our able executive director. She's listening to the same questions that you're asking. And in case it's something that we can pursue, I think she has heard you, Dr. Shalin. Thank you so much. I have a friend, Dr. Alida, is asking, do you guys have any harm reduction program, especially to people who are drug addicts? Currently, we don't have that, Alida. Since, as I have explained to Charlene, most of our work is on telemedicine and remote work that is mostly asynchronous. When I say asynchronous, it's a text-based messaging system and a platform where we offer services to clinicians to help their patients when they cannot refer patients to other hospitals. So if you have a patient that is diabetic and sometimes they are very sickly, but this patient cannot afford to go to an higher facility, you can recommend the case to us and we'll try and respond to them. Dr. Paul and other physicians on board make sure that those cases are responded to. So I don't want to keep people so much. I have other questions here, Dr. Paul. I think I will let you write them down, and then you will respond. You will respond them in the text, and then I will forward to everyone. So the first question
Are
is,
you able to, could I ask you, are you able to copy all the questions and email them to me?
I can do that.
Yeah, if you do that to me, then I'll make sure that I've got them all as the patients, as your colleagues asked there, and then I'll make sure I respond to all of them.
Thank you so.
That's easy.
Thank you so
Because I
much.
mean, for example, just one quick response to the next question is about using alternative medicine. Excellent question. Is there any risk of combining traditional and alternative medicine for HIV treatment is one way of asking it. I have no problems with alternative medicine, realizing that the science may not be there in the same way as the science is there for other forms of, for traditional studied treatments.
Thank you. So that one will be included in the questions that you will respond.
Perfect.
Yeah, so I think even the other two questions are, can you talk more about discordant couples?
What does that mean?
Discordant couples are couples that one is HIV positive and the other one is HIV negative.
Okay. I'll get you information on that for sure.
Yeah, and the last question is on patients who fully show signs and symptoms of HIV, yet they test negative. Some of them may have herpes and still test negative. This is a question from Joy, and I think as Dr. Paul will be getting more response on that, it goes more on the immunity. If the immunity is compromised at any time, you are capable of getting these other comorbidities. But Dr. Paul will respond to that later.
Good. That's perfect. Well, thank you so much, everybody.
Thank you so much. The last question was, can I repeat my mobile number? It's 0712559438. If you want an email, Anthony@addisclinic.org. Anthony is ANTONY at Addis is double D, IS clinic, it's one name, .org. So anytime that you want to reach out to me via WhatsApp, via text, via email, and I will respond to you. Thank you so much, Dr. Paul. As we close, because
as always, it's great to see you, and we'll see you next month.
I have kept everyone 20 minutes more, but I really apologize. Reach out to us.
Wonderful.
Thank you so much. Dalal, I will give you room to end it for us if you are here.
I want to thank Dr. Paul and for all his input and the fact that he's also going to respond to all the questions. And Anthony, thank you for moderating today. Very much appreciated. Dr. Paul, we'll discuss the topic for February. If anyone on this webinar has ideas of what they want to hear, please send it to Anthony.
Yes, for sure.
That would be great. Thank you so much.
Thank you so much. As you have heard,
Happy New Year there to everybody.
Bye bye, everyone. Thank you so much, Dr. Paul.
Thank
we'll
you.
Talk
Bye-bye
later.
now. See you soon. Bye-bye.
Bye bye, everyone.